Hello, everyone, and welcome to this audio podcast. This audio podcast as part of the Interlobular branch edition. This audio podcast as part of a SZtorm Communicade. This audio podcast as part of a Squadron G-Force. And this audio podcast as part of a SZtorm Logistics production. In this audio podcast, a little bit around the sort of a little bit in around the multidisciplinary or MDT aspects in around HSP and sort of in around the biomedical aspects and sort of the sort of clinical aspects around HSP as well. So streptococcus vaccines and viral infections. So, for example, measles, varicella, rubella, hepatitis A and B, tuberculosis, mycoplasma, and Bartonella Helicobacter pylori. Are stated as some of the triggering factors in the literature. This is HSP is generally a multidisciplinary disease as it sort of as it affects can affect the skin, can affect the skin, joints, gastrointestinal system, kidneys, and in addition, more rarely can have an effect on the CNS or the central nervous system, heart and in males also in around the lower parts of anatomy as well. Its pathogenesis and causal factors have not been accurately identified yet. Viral and bacterial infections, drugs, vaccines, food allergy, and even insect bites have been considered in the etiology of HSP. It is thus important to appreciate that we're supporting clinicians with laboratory diagnosis. HSP requires an MDT, a multidisciplinary laboratory practice. In the peer-reviewed works, there is a sort of an overview in linking HSP and multidisciplinary team laboratory practice. So, for example, in around the laboratory investigation and sort of the typical findings around specific investigation, the laboratory investigation. So a full blood count, an FBC may indicate anemia and sort of a leukocytosis, erythrocyte sedimentation rate or ESR, a normal or slightly raised, are not indicative of HSP in solo. Coagulation is normal. It can be normal. The biochemistry, the renal function may be normal with raised creatinine, low albumin, and might be related to gastrointestinal disease. Anti-streptolysin O titer and anti-deoxyribonuclease B or anti-DNase show that the investigation that can confirm preceding streptococcal infection. This does not exclude HSP. It does not exclude HSP as it may precede HSP. However, and the urine dipstick and protein creatinine ratio. There's hematuria and proteinuria. There's in around the septic screen. if diagnosis is unclear, if diagnosis is unclear and a purpura is present. So some the investigation or the laboratory investigations and the typical findings can help clinicians to determine and identify the identify sort of HSP sort of symptom in around the HSP symptomologies. The HSP clinical pathological findings are as follows. So significant the significant clinical pathological differences with IgA nephropathy. Renal symptomology is in around between 30 and 70%. Some young adults or some adults some young adults or young people or adults develop rapidly progressive glomerulonephritis. 70% are age between 2 years of age and 11 years of age, and rare in adults or infants 1 year or less. And higher rate of renal involvement in children in peds ages 10 to 18 years, and there's an association with atrophy in one in third in a third, and respiratory infection may follow. There's also related to the IgA nephropathy due to elevated IgA. Circulating immune complexes with IgA creates sort of similar sort of renal lesions. High serum galactose deficient immunoglobulin A1 level is also demonstrated. Serum creatinine, proteinuria, hypertension, cellular crescents, and glomerular necrotizing lesions and chronic renal lesions. Chronic renal lesions are associated with the development of renal failure, and there are variable recurrence rates anything between 12% and just around 70% post transplant. However, it is not clinically. However, the variable recurrence rates are not clinically important, and in around the sort of HSP sort of microanatomy around the kidneys and the small blood vessels, in around the acute aspects of around the microanatomy and kidney and the small blood vessels. There's leukocyto sort of blastic vasculitis of small vessels due to deposition of IgA immune complexes. There's diffuse proliferation of mesangial cells and matrix without significant involvement of capillary walls or lumen. There's segmental necrotizing lesions in around 50% and endocapillary proliferation around 13%, and cellular crescents in cellular crescents where there's glomerular acute and chronic inflammatory infiltrate. And around the chronic aspects of HSP, there's glomerular sclerosis, tubular loss, interstitial fibrosis, and haline atherosclerosis. And in around the skin aspects of HSP, there's hemorrhage and necrotizing vasculitis in dermal small vessels which contain IgA, and vasculitis is present in other in other organs, but usually not in around the kidneys or around around the renal anatomy aspects. That draws this audio podcast to a close. This audio podcast as part of an Interlobular branch edition. This audio podcast as part of a SZtorm Communicade. This audio podcast as part of a Squadron G-Force. This audio podcast as part of a SZtorm Logistics production.